Good morning. Greetings from Dhaka. I am very much grateful to organizers for having me here. My topic is capsulorhexis in different situations. I have no conflicts of interest. We know cataract surgery is rapidly evolving area in ophthalmology, and optimal outcomes of cataract surgery largely depend on the successful performance of capsulorhexis. So, an ideal capsulorhexis must be round, continuous, well-centered, and overlap the implanted IOL around its capsular circumference. An appropriate size of rhexis varies between 5 and 6 millimeter. Ideal size is 5.5. In eyes with weak zonules, capsulorhexis can be kept 0.5 to 1 millimeter larger than the optic to prevent capsule capture. So at first, capsulorhexis capsule must be stained with any type of, in case of any type of cataract, central continuous curvilinear capsulorhexis or opening in the anterior capsule can be fashioned by creating a small tear in the anterior capsule, and it is advancing the resulting capsular flap into a circular shape by guiding the leading edge with the cystitome, or it can be done by a capsulorhexis forceps by grasping the leading edge with, and it is advancing the tear with frequent grasping and re-grasping, and in between we have to use several times of OVD. Now, I will discuss various techniques of capsulorhexis along with variations in special circumstances. For example, small pupil with cataract, white cataract, hard cataract, and in pediatric cataract. We know small pupil makes virtually every steps of cataract surgery more problematic. Actually, small pupil limits the size of the capsulorhexis. So, we could do rhexis with the help of excessive use of high molecular weight OVD. Where we advancing the capsular flap underneath the pupillary border to get the desired size, and several times we have to use OVD here. Or we could do capsulorhexis in small pupil cases by using flexible iris hooks to get the desired size of the capsulorhexis. Or we could use pupil dilating devices to complete the rhexis here. Here I show B-hex ring I use here. Now come to white cataract. We know intralenticular pressure is high in case of white cataract, so recommended surgical technique to minimize the risk of radial extension of the anterior capsule. At first we have to flatten the capsule by using highly cohesive OVD. Then at first we could do initial small rhexis. Here I use cystitome, or we could use capsulorhexis forceps, then decompression of the bag, and secondarily I do large rhexis. In case of radial tear or Argentinian flag sign, when happens, it has to be taken care, so we could continue phaco by doing half circle rhexis, at first distal one, then proximal one, and remaining portion of the phaco should be done very gently, cautiously, and we could place the IOL here perpendicular to the tear. In case of hard cataract, here after staining capsule, we could do capsulorhexis a little bit larger than usual one to minimize the stress over zonule during phacoemulsification. And here we have to use OVD more frequently. And rest of the phacoemulsification we could do whatever we prefer. In the event of occurrence of peripheral extension, if occurs, capsulorhexis forceps can be used here to change the direction of the tear when it happens. It can be, capsulorhexis forceps can be used to hold the torn flap as near to the base as possible and pulling it toward the center of the pupil and connecting it to the initial flap. Pediatric anterior capsule is more thinner, stronger, and more elastic than adults. So capsulorhexis, we could do capsulorhexis. There is a risk of peripheral extension is more, so needs more precise surgical maneuver. Here we could use high molecular weight OVD to flatten the anterior capsule and construction of slightly smaller than desired rhexis, because with the stretch in the anterior capsule, the opening would be larger at the completion. Femtosecond laser-assisted cataract surgery paved the way to a new era, especially in white and hard cataract, to achieve desired capsulorhexis. This technology gives a drive for more consistent outcome than that are achievable by an experienced surgeon. Here, less variation in centration and size, uniformly circular and precise diameter, and reduce the risk of radial tears here. Optimum capsule overlap. Therefore, improved refractive and visual outcome due to more predictable effective lens position. Higher cost of the procedure remains the major limiting factor. Thank you all for your patient hearing.
Well, thank you, Dr. Firdaus. I think you have covered each and every aspect of capsulorhexis. And just to sum up what she has said, I mean, capsulorhexis is the basis of any phacoemulsification procedure, because the capsulorhexis is not only an art, but it's also the efficiency and the proficiency that decides how good a surgeon is and how good a surgery is going to be in the final post-op period. So I think she has covered every aspect, but the two most important I would rate it as, one is the hypermature cataract, where people might have difficulty, and second is the pediatric cataract, where actually you intend to do a 3 millimeter rhexis and finally it goes into the 6 millimeter rhexis. But I think Dr. Firdaus has covered each and every aspect of the capsulorhexis, and thank you so much, ma'am.
I think in my opinion, whatever the cataract is there, use the high viscoelastic. That will solve the purpose. If the extension is going on, just retrieve, pulling towards your own side. So that will somehow will save you the extension. And Dr. Firdaus, you have done wonderfully well. You have really good presentation.
Very nice videos indeed. And one more thing I want to add for the beginners or for PGs, that capsulorhexis preferably should be done from the side port, so that your antechamber is maintained, and as sir said, high molecular visco is always preferable. in dire
Usually-
situations.
Usually I practiced within the side port only in case of hypermature white cataract.
Yeah.
Otherwise,
Side port
all are
has
through
also
the-
one advantage that
Yeah.
you have your capsular axis very thin, microfine capsular axis you use. But from main port, if you use a utrata forceps, that leads to the escape of the viscoelastic and chamber collapses. And that may create a lot of problems. So side port, as he suggested, side port is a very wonderful place to perform the capsular axis. I think one should try it, especially PGs.
Thank you.
So one more thing for SICS, you need little larger capsular axis so that you can deliver the nucleus
Yes,
with ease. So that is two things I want to add. Thank you so much for your nice presentation. Thank you.
I think
We pass on to the next speaker, nucleotomy techniques in phacoemulsification, Dr. Rajesh Ganeshwani.
Good morning, everybody. I thank the Scientific Committee of All India Ophthalmological Society for giving me this opportunity today to talk on nucleotomy techniques in phacoemulsification. I am Dr. Rajesh Ganeshwani. I'm not going to the next slide. Next slide is not functioning. Yeah. Right. The aim of nucleotomy or the nucleus management is to remove the nucleus from the capsular bag without damaging the corneal endothelium, iris, and the capsular bag. Principles of nucleus removal is to mobilize the nucleus, break the nucleus into smaller fragments, and emulsify and aspirate each fragment through the phaco tip. There are three basic nucleotomy techniques. One is the divide and conquer, or we can also call it as the 4-quadrant technique, the stop and chop, and the direct chop. Direct chop can also be done either a horizontal chop or a vertical chop. Divide and conquer is a basic technique and very easy for the beginners to master, and with a good rexus of about 5 mm and a good hydrodissection, optimal phaco power is set depending on the density of the nucleus, and vacuum is set less than 100 millimeters of mercury and with a flow rate of about 20 cc per minute. A groove is made which is called a sculpting or the trenching, which is deeper in the center and shallow in the periphery. This groove is widened in hard cataracts, and we should always be very careful not to push the nucleus while doing this sculpting. The nucleus should be emulsified the moment we touch the phaco tip to the nucleus. The groove is deepened slowly and almost up to 90% of the depth of the nucleus, or till the time that we see the red reflex or the red glow. Rotate the nucleus about 180 degrees, and the sculpting should be completed on the other side also. And appropriately rotating it again, we make a plus sign on the nucleus, as you can see here. So with this, we get about 4 quadrants we can divide the nucleus into these 4 quadrants, and these are separated using the two instruments. One is your phaco tip, other one is a side port instrument that you introduce. Either it can be a chopper or a Sinski. While when we are trying to break this nucleus into smaller pieces, we should be very careful not to cause any undue damage to the zonules or to the posterior capsule. We should exert just that much pressure to separate the posterior plate of the nucleus. That much is enough. After that, increasing the vacuum to about 250 to 300 millimeters of mercury, and increasing the flow rate to about 25 to 30 millimeters, 35 cc per minute, and using the quadrant removal setting of the phaco machine. Each piece of these 4 pieces that we have made, we have to lift each piece and catch the piece at a corner or a sharp edge, bring it to the center of the pupil, and emulsify it in the center of the pupil, either at the plane of the rexus plane or at the pupillary plane, just above the nucleus. Should make sure that your second instrument should contain the nuclear pieces from flying into the anterior chamber and hitting the corneal endothelium. Then, coming to the stop and chop, of course with a good rhexis and a good hydrodissection. Making sure that the nucleus is mobile in the bag, a groove is made in the center of the nucleus and the groove is widened and deepened. The width should be at least 1.5 to 2 times the width of the phaco tip, and this will debulk the nucleus right in the middle of it. Nucleus is rotated to the desired position and the groove is completed on the other side also. And using both the instruments, again taking care not to damage the zonules, gently but firmly divide the nucleus into 2 pieces. Just to save time, I'm running the video a little faster, but this is not the speed at which you should be doing. You should be going very slow. Make sure that the posterior plate of the nucleus is also separated, and you get two halves. Each half of the nucleus now is lifted, again rotating it to your desired position, lifted and chopped, catching hold of the bulk of the nucleus. Once you get a small fragment which is free from the half of the nucleus, you can either emulsify that small piece immediately, or you can make multiple pieces by repeating this chopping technique, and these small pieces can be emulsified safely and conveniently. Again, your second instrument should help retain or contain the nuclear pieces at the pupillary plane or at the rhexis plane, and not to allow these pieces to touch the corneal endothelium. Direct chop can be either a horizontal chop or a vertical chop. In the horizontal chop, initial groove is made in the center of the nucleus and the phaco tip is buried into the nucleus. Chopper is taken gently under the rhexis up to the equator of the nucleus. The phaco chopper and the phaco tip are moved gently and firmly towards each other, causing a horizontal chop. Both the chopper and the phaco tip are separated from each other so that the nucleus pieces are separated, as you can see this here. Once these pieces are separated, these can be removed at this stage, or you can create more for creating more space for further chopping maneuvers. Horizontal chop is a very effective technique with less stress on the zonules, but it may be very intimidating to the beginning surgeon. Vertical chop, of course, we need a very good big rhexis and a good hydrodissection. An initial groove is done in the center of the nucleus that is deepened to about 60%. And then the vacuum is increased and the phaco tip is buried into the substance, just like a lollipop, just buried into the substance of the nucleus at the center. You can use a chopper of your choice. A sharp chopper is preferable, and this is used to bury vertically above the phaco tip and press down. Simultaneously, phaco tip is moved vertically up towards the chopper. Lateral separation is done, thereby breaking the nucleus into smaller pieces. And each piece can be emulsified with ease at the level of the rhexis plane or at the pupillary plane. Tips for the beginner is, do not be in a haste to complete your procedure. Go one step at a time, be confident in your movements, and first and foremost, know about the controls of the phaco console, foot pedals, and the microscope before starting your case. Thank you very much. Happy phacos.
Well, thank you, Dr. Rajesh. Wonderfully covered each and every aspect of how you need to deal with the nucleus. Just to re-emphasize on two things. I mean, most of the beginners are too afraid of a grade 5, grade 6, that what they call a super hard cataract. But believe me, the softest of cataracts are even difficult to tackle, and it's a totally different ball game dealing with those really soft cataract. So wonderfully covered, Dr. Rajesh. And one more point that I want to emphasize on is, if it's a grade 2, 3 plus cataract, the key is separating the entire piece, means till the posterior plate, it should be totally separated before you actually start eating up each individual pieces. So thank you, Dr. Rajesh. May I have any questions from your end? You can just take up the mic and ask the questions.
So to add to excellent presentation, to add is again the emphasis should be given to the visco, that high molecular visco many times helps you in hard cataract. because in nucleotomy techniques you are dealing with the surrounding structures, iris and endothelium and PC. So you should take care of all those things, and I think visco is very important to use in hard cataracts. And second is divide and conquer technique is still a gold standard for any type of cataract. You can, for the beginners, I think it's very good technique to follow. So I think in all types of cataract.
Yeah, divide and conquer with a Venturi machine.
Yeah.
No, divide and conquer with a peristaltic machine, not a Venturi machine.
Yeah.
A beginner should not go to a Venturi machine. Beginner should always go with a peristaltic machine.
Yeah, peristaltic machine is for the beginners and Venturi for the experienced people. Yeah. So next speaker, I think.
We have a very experienced surgeon, Dr. Dharmendranath. He's going to tell us more about align chopping in phaco.
Thank you very much. My topic of today is align chopping in phaco. It is a different type of concept and different instrument. So Nagahara initially, he presented his paper 1993 in ACRS regarding the chopping. So there are so many choppers and techniques came: Nagahara chop, stop and chop, pop and chop, bimill chop, quick chop, pre-chop, tilt chop. And in my opinion, there is one more, which is known as align chop. Two main categories are there. Nagahara is a horizontal chopping, vertical chopping is too, as doctor has already discussed a lot. So all chopping techniques, manual instruments are used, replacing the ultrasound power, which is very important, just for the efficiency, safety, and reduces stress on the capsular bag. During the scalp, the nucleus is fixated by the in the capsular bag, more stress on the zonules. To reduce that, there is a kinesthetic, it's a kinesthetic, and we do not require much of the red reflex, and is done in mature cataract, and central 2 to 3 millimeter pupil zone is required in this technique. Is used for brunescence nuclei, white cataract, weak zonules, capsular exterior, and the small pupillae. So these are the horizontal choppers, they are the vertical choppers, they are the differences between the horizontal vertical chopping, you know very well. And why this concept came: once you are doing the chopping, what happens? You hold the nucleus with a high vacuum. Even then, sometimes it rotates. It's a very common problem in the hard mature cataract. Just see, these are rotating. So the idea came into mind how to fix it and how to chop it nicely. Just see once again, it moves. It so happens in those cataract where the cortical matter is little liquefied. So it's not moving now. So the align chopping was designed by us. It's a blunt tip, 1 to 0.5 millimeter or 2 millimeter long. Blade is there. The blade is bent at 30 to 40 degree, 2 millimeter away from the blade. And it is 26 gauge shaft. Left-handed surgeon has left band, and right-handed surgeon the right band. So is the three-dimensional picture. So you can see very well, there is a blade, there is a band. So chopper is angled, insert at 30 to 40 degree away from the main port, follow the curve of the instrument. Because this is three-dimensional, so you have to follow the curve of the instrument. That is very important. Just see in the hard cataract how it cracks. Hold half of the nucleus, and it is chopped from anterior posteriorly directly. It's a horizontal chopping. The rotation also facilitated with the same instrument. Hold it in the center, go to the periphery, and you just chop it towards the tip. This is centripetal force against the tip, and this is how it chops. So you can divide the nucleus as many fragments as you can. The more you have the fragment, the less is the corneal damage. So this is how, this is full thickness chopping is being done here. Keep rotating and hold again and chop it. We are not cracking it. Classically we are chopping it. In other instruments, most of the time it's a crack, not a chop.
Now, make a big CCC. In hard cataract, try to do a 5.75 CCC. Hold, make a crater in the center, just see, and hold it with a high vacuum. Follow the curve of the chopper. This is angled. Hold the nucleus with a high vacuum, more than 300, 400, or if your machine allows to 500, hold it with the 500 vacuum, and see going to the periphery, equator, and you just chop it, and it cracks full thickness. It doesn't allow the segment to rotate, which is very important. Again, rotate it and hold it again and see the chopping. So main objective is to chop towards the tip. That is alignment. Phaco-tip alignment chopping is this. Use of the chopper in grade 2 and grade 3 cataracts. In the soft cataract, you can do the vertical chopping with the same instrument because this chopper comes in the two forms, blunt and the sharp. Sharp for the vertical chopping and the blunt is for the horizontal chopping. See both here is the vertical chopping is done. And if you see, one side is the soft cataract and another side is the hard cataract. One video is not running, please. Okay, no problem. So have you seen this? This is a white cataract holding in the center with a high vacuum, go under the rhexis margin and just chop it. And it is a beautiful instrument to do the lateral separation of the fibers. You have to do every maneuver very softly and gently. Don't push it down because sometimes you use a sharp instrument because it cuts through and through. You can traumatize the posterior capsule with the sharp instrument. So just take a small instrument which comes as 1.1 millimeter, 1.5 millimeter and 2 millimeter blade. If you are doing the femtosecond, the button is taken out and do the gentle hydrodissection, take out the bubbles. I'm sorry taking a little more time. It's a beautiful instrument for this kind of situation, and the bubbles they are. Just only one video I will show it to you, how it works actually in these cases. Just go inside and your chopper is inside again, follow the curve at 30 degree and hold pre-segmented nuclei and separate it, because this angle facilitates in separation of these. This is how it is separated. Thank you very much.
Thank you so much, sir. I mean, he has demonstrated how a small modification in the angle and the degree of one instrument can make things wonderful. Thank you so much, sir.
Thank you, sir. You have shown very nicely angle chopper. I didn't.
It is just a simple modification in your original chopper. Just bend a little to 30 degree. Because you are 30 degree, it means you have to be away from the main port 30 degree.
Yes.
And then the force come in the alignment of the tip, then hard cataract, they never rotate. What usually happens in day-to-day practice.
I want to use it. Thank you.
Yes, this is, they are in the Pericon, I have no financial interest, but Pericon people, they are.
It's very nice modification, sir. It's very useful because many times during chopping, the nucleus rotate. And that can be avoided with this instrument. Thank you so much, sir,
Thank you.
for a wonderful invention.
May I invite the next speaker, Dr. Manish Wankhede, to tell us more about tricks and tips to manage post-uveitic cataract in synechia.
Thank you,
Dr.
sir.
Manish is a very dynamic ophthalmologist from
Khamgaon.
Khamgaon, yeah, Vidarbha, Maharashtra.
So at the onset, I thank the AIOS Scientific Committee and Heritage City Kolkata for having me here. It's nice to see nearly half of the hall is full, and I'm here, and this is the man who is going to bore you in next 6 to 7 minutes about uveitic cataract. So let us start with the preoperative consideration. We need a detailed preoperative clinical evaluation, and the most important thing is anterior segment, posterior segment evaluation with detailed documentation for medical legal purposes, because these eyes are already suffered a lot. The absolute inflammation control for 3 months is a pre-mandatory condition while achieving the better outcome in such cataracts. What is the absolute control of the inflammation is a no cell in the anterior chamber for at least 3 months of the period, and vitreous is almost free of the cells. Of course, this does not work when it is in a Fuchs iridocyclitis. Preoperative management, topical steroid does well with most of the anterior chamber uveitis, anterior segment uveitis, but certain cases may require systemic steroids and topical NSAIDs, and we also need to continue our rheumatologist prescription, physician prescription for next 3 months from the date of surgery. At least we should ensure that patient is taking that medication, because it will help us a lot in controlling the inflammation. Certain exceptions like an herpetic uveitis, we need to continue the antiviral drugs for 1 week prior to the surgery and for 6 to 8 weeks post of the surgery. We need to be more friendly in this situation with our colleagues like a cornea surgeon, glaucoma specialist and VR surgeon, because these eyes may have an keratopathy, coexistent glaucoma, and need to be combined with the various retinal surgeries. Need to be friendly with rheumatologist and physician, because they will save us in systemic medication perspectives. Now we will combine a small tips and actual surgical case side by side, because what we see can be something different. I am presenting a case of an elderly female who has severe kyphoscoliosis because of port spine. She has lost one of her eye due to tubercular uveitis. She is high hypermetropic with IOL power of 36 diopter. There is sickle cell pupillae due to a severe synechis and near mature cataract. This was her actual attire, and this is how I prepared my OT table for her surgery. So intraoperative consideration, we need to minimize the iris handling, minimize the bleeding. We need to be modest, gentle, and need not to be an alpha surgeon in such cases. We need a large rhexis, pupil dilating devices, capsule stabilizing devices, and yes, vitrectomy should be ready. We should be ready mentally for all kind of complication we can think of. So this is the case. Generally, while operating such cases, the perivalvular block or eye operating under anesthesia is preferred. When such a severe sickle cell pupil is present, we should remove the pupillary membrane first, and this may dilate most of the pupils at the very beginning of the cases. But when the iris is through and through adherent to the underlying capsule, mere removing this membrane might not help, and we may require more efforts for this. I have gone with a classical pupillotomy procedure and incising the pupil sphincter at multiple places. Nowadays it is hardly done because of advent of many pupil expansion devices, but in that case, in this case I required it. When I think the pupil is still not expanding enough to operate safely, I go ahead with a stretch pupilloplasty. And this can be one of the tips that anything can be may have to be done while expanding the pupil in such cases. Use of pupil expansion devices is always advocated, but in this particular case, being one-eyed eye, high hypermetropia, shallow anterior chamber. To avoid the crowding, I use the classical techniques of expanding the pupil. As Jolly ma'am has already discussed with us, the large rexis is always required in such cases to minimize the post-operative inflammation. And while doing the nucleotomy procedures, most of these cases are generally have softer cataracts, fluffy cataracts, and the nucleus is not so hard, and mostly a small chops and vacuum may have done the work preferably. We need to be an artist while performing these cases because there is multiple coexisting problems like zonulopathies. There may be a pre-existing PCRs. There may be a multiple intravitreal injections this patient, these eyes may have experienced. After removing a thoracortical wash, the IOL placement, generally my choice is a single piece hydrophobic IOL, but in coexistent elements of zonulopathies or a rare situation, we can use a multi-piece hydrophobic IOLs. In this case, I thought that the rexis is little bit smaller than required, so I go ahead with expansion of the rexis after IOL implantation. Smaller rexis can lead to a phimosis more in such cases. So one more small trick I will like to share with you. I generally use diluted triamcinolone intracamerally, do a complete washout, and preferably triamcinolone subtenosely and subconjunctivally to minimize the post-operative inflammation, to prevent the synecdoche in post-operative period, of course with a close watch on intraoperative pressure. And post-operative management, as we all routinely perform in all cataract surgeries, but for this we need a topical cycloplegics to be continued for more period. We need a systemic steroids, and we ensure that disease modifying agent and other biological agents started by physician and rheumatologist should be continued. So we need to be again friendly with a rheumatologist and physician if you have more of such cases in your area. So this was the case of one-eyed patient, 36 diopter from start to end. And I hope this presentation will make you a superman in uveitic cataract. Thank you.
Thank you, Manish, for your excellent presentation. Very nicely demonstrated the techniques, how to remove the synechia. And the 2-3 things I want to just highlight is, one is the perioperative steroid that is must in such cases, and NSAIDs. And also cycloplegic post-operatively one can use to curb the inflammation and pain, and also delicacy in your maneuvering during surgery, that is must. Whatever techniques you are using, your iris should be delicately handled, just like a baby. So that is 2-3 things I want to just highlight. Thank you very much for your nice presentation.
Thank you, sir.
Dr. Manish, I would like to add a little small thing. Before doing the pupilotomy, you should do the stretching first.
Yes.
Number one. Number two, if the stretching fails, then you can use the mechanical devices. I think that will be better rather than cutting the sphincters all around.
Yes.
I think you will agree me.
Yes, sir, definitely.
And how many milligrams you start 1 week prior? Prednisolone or steroid, whatever, oral steroids?
Sir, topical steroid generally I start 3 weeks prior to the surgery.
Does any oral steroids have role?
Sir, of course, if there is a pre-existing history of cystoid macular edema, then severe rheumatic diseases, and also I follow one rule: if patient says he is taking the anti-rheumatic medication like disease modifying agents for more than 3 years, I generally prefer 40 milligram of omnacartil irrespective of the weight of the patient 5 days prior to surgery.
Prior to surgery?
Yes, sir.
And post-surgery, do you recommend also?
Sir, post-operatively, most of the times the subtenon, triamcinolone and triamcinolone wash intracamerally does the work.
But that's good.
In the cases if on the 5th day I found their cornea is not so lustrous and the anterior chamber is also need some more attention, we can start the steroids with tapering doses.
Yes,
but
yes.
if we ensure that patient is following his rheumatologist treatment meticulously, no need is generally required in oral steroids.
So you mean autoimmune disorders should be taken very carefully?
Very carefully.
Thank you very much.
Dr. Manish, excellent surgery. I would like to add. definitely this patient would have given you a lot of blessings for making her see again this world. Instead of me being a very short man, instead of raising the head end so much, you must have almost done the surgery as standing up, right?
Yes.
The other way of doing it is raise the bottom up.
Yes, sir. I have
Put
tried.
a lot of pillows in the bottom. The head will come into the the ring of the table, and you can do your surgery comfortably.
Sir, I have tried raising the bottom of the table. I have tried the placing bathroom stool below the
Yes,
breast of the
exactly.
patient.
Yeah.
But sir, being this was a thinner patient and slim built, but if he is a little bit of bulky, then the abdominal pressure increases, the IOP and the iris start coming all.
That's very good. That's very good. Thank you very much.
Well, thank you, Manish, for covering every aspect. And one very interesting thing that I found in your video was putting a triamcinolone in the anterior chamber and washing it and giving it subconjunctivally also. That also works because the most concern for any uveitic phacoemulsification is the immediate post-operative reaction and the inflammation that you get. And I think that serves the purpose for both ways. Now the next speaker I would, yeah, please.
I want to add one point, that is I prefer to use multi-piece IOL in small people cases usually. Just want to add. Thank you.
May I invite the next speaker, a very innovative person himself, and he's going to tell us more about the innovative way to deal with intumescent cataract. And Santosh Agrawal happens to be the president of Maharashtra Ophthalmological Society. All yours.
Thank you, Gopal, for your kind words. Thank you, Chairman. And today I am going to present an innovative technique to deal with intumescent cataract. It's very rewarding. This is an intumescent cataract, white cataract. Then 2 side ports are made. And now the 24 gauge needle is bent and it is penetrated inside the capsular bag to aspirate the liquid cortex, and from the other end simultaneously you are injecting the visco. And now this is the first CCC, small CCC I have made. Then I will enlarge it later on. I am taking out all the cortical matter from the capsular bag, which is, there is a high intracapsular pressure in intumescent cataract. So we have to decompress it, debulk it, and then we can perform the nucleotomy and other phacoemulsification techniques as usual. So many times you encounter hard nucleus, sometimes you encounter soft nucleus in intumescent cataract. So young people, most of the time it is a soft cataract. This is another case, again 2 simultaneous incisions. The important point is simultaneously you are aspirating as well as pouring the visco inside the antechamber from the other end. So this is the aspiration with the needle. At the same time you are pouring the visco from other end. I have also discovered one automated technique of visco delivery, but one can go for manual visco delivery also. So this is a small capsular axis I have made, and then I have aspirated and decompressed the capsular bag so that there will not be any Argentinian flag sign. So other phaco method is same. Again the 2 side ports I have made. This is the aspiration mode. I have aspirated the central part of the cortex through the incision, and from other end I have poured the visco inside the antechamber so that the antechamber is well maintained, your capsular anterior capsule is flattened, and there is no risk of Argentinian flag sign. Instead of this anterior opening cannula, I have used the end opening cannula so that the cortical removal is easy. After decompressing, I have just take the nick under visco and enlarge to the desired size. So this is a 2-stage capsular axis, very rewarding, very safe. For last 3-4 years I am following this technique without any Argentinian flag sign. Again, this is the old video, the same 2 side port one for the aspiration, one for pouring the visco simultaneously. So concurrent action is very much required. Otherwise, you can encounter Argentine flag sign on the puncture only, at the time of puncture only. So you have to be cautious. You have to pour the visco so that antechamber is well maintained. Now this is the second stage, capsular axis. Again the same technique, 2 side pours, aspirating central cortex, decompressing the capsule and pouring the visco from other side. This is the main important point in this technique. Many people tried punch capsular axis and other techniques, but what I found, the peripheral part is not taken care of, so many times you get Argentine flag sign. It will just decompress the central part only. Again, this aspiration and pouring the visco from other side, it will save your life. So decompression of the capsular bag is the main important point in intumescent cataract. And before going for any this type of cataract surgery, you can go for intersegment OCT also to find out where is the cortical material or the fluid part in the capsular bag. That is also helpful if you have intersegment OCT. This is a hard cataract. So many times in old age, you find this type of cataract. And in some cases, the capsular margins are fragile in intumescent cataract. So you have to take care of that also. So
Agrawal, main objective of these cataracts are to perform a baby rhexis, and it solves the purpose. Then you just wash out the intra-capsular, all the liquid material or flakes, what I say, and then after you can enlarge, as he has demonstrated all in videos. So he is, one time he is using irrigation. So the main object, principally at the beginning, we were also maintaining the AC maintainer. So in place of the AC maintainer, you can use the continuous irrigation mode in the anterior chamber. You will be quite comfortable in that situation. Very well done, Dr. Subhash.
Well, Dr. Santosh, a very innovative idea.
Yes,
and
yes.
if I have to sum up that what you need to prevent the extension of the rhexis are basically two things. One is tackling the intralenticular pressure.
Yes.
And second is making this capsule flatten. Because the more it's going to go convex, the chances of extension are more. And very wonderfully tackled both these aspects of the preventing that extension of the rhexis. Thank you so much.
Dr. Santosh, you're aspirating with a needle, right?
yeah.
Did you connect it to your phaco machine or you're doing it with a syringe?
No, it's a phaco machine.
Connected it to the phaco machine?
Yeah.
Right. Yes.
Sir, I would like to ask, how do you aspirate with the one hand? Like you're putting the visco with the other hand, but when we usually do aspiration, we need two hands for aspiration.
I have invented that automated visco delivery system also.
Okay.
So from one end, I am just with the foot funnel, I am pouring the visco inside the antechamber, and from other side, that is attached to the phaco machine, aspiration port. So aspirating with the automated technique only.
Do you
But
have video?
If you don't have that automated visco delivery, you can inject with the hand also.
No,
problem.
aspiration.
Aspiration with the phaco machine.
Phaco machine. Okay, thank you.
How much vacuum did you fix for that? Vacuum?
Vacuum I am using Venturi, so 200 to 300.
While aspirating the liquid cortex, yeah.
Have you ever encountered the extension of the anterior capsule?
No, I didn't encounter because I am doing very small capsule rhexis initially.
Baby rhexis.
Then I am aspirating all the mid-peripheral cortex.
Yes.
I am decompressing it, and then I am going for second.
Thank you.
CCC.
Thank you very much, Doctor.
Thank you, sir.
Thank you, Dr. Santosh. May I invite the next speaker, the person from a rural area a small town making it big, Sean Chinchole, to tell us more about phaco in small pupil.
Very good morning all. Dealing with small pupil in cataract surgery, the common causes for small pupil is advanced age, post-uveitic cataract, pseudo-explosion syndrome, diabetic patient, floppy iris syndrome, high hypermetropia and prolonged myotic therapy, neurological conditions. Problem that encountered during cataract surgery, that is first is just doing the capsular axis, difficulty in visualization of axis margin leading to ill judgment of size, shape, and if any extension to periphery. Hydro procedures inability to judge the correct dissection plane leading to difficulty in rotation of nucleus. During the phacoemulsification, smaller the pupil, poor the red reflex, which can lead to difficulty in judging the depth and strength that may lead to PCR. Risk of catching pupillary margin with phaco tip, this happens usually. Involvent capsular catch and capsular trauma with chopper can cause posterior extension and that leads to PC tear. Difficulty in cortical aspiration and implantation of IOL. This leads to iris bleeding, increased risk of iris damage, iris prolapse. Then again, if the iris catch is there, again the pupil will become small and the rhexis will be small, incomplete evacuation of cortical matter, problems in incurring in the bag IOL placement, difficulty with proper alignment of toric IOLs also. How to manage the small pupil? The posterior synechiae can be managed with Midratic, as Dr. Manish had told so many things about that. Subconjunctival induction of Midracan, if patient is using myotic, ask to discontinue for 3 weeks before surgery. How to manage cataract in small pupil? Surgeon techniques and pupil expansion technique depends on pupil size and biomechanical properties of iris. What is the critical diameter for pupil to become a small? So these are the small pupil, even you can do it in 2 millimeter, 3 millimeter, 4 millimeter. The pupil size relieve to surgeon's skill and technical skills, intraoperative situations, iris tissue properties. Surgeon skill and techniques, see, even this is without using any pupil expansion device or hooks. Use good OVD. Here I suggest decrease the fluidic parameters because sometimes if the parameter is more, again that will lead to iris will come through the main port or side port incision. Always use, as sir said, whenever you are using the phaco tip inside, go for vertical chop technique because sometimes if you are using vertical one, you can't damage or you can help that nucleus to bring towards the phaco tip and that will definitely help. Here also sometimes you can see there is iris catch. So, but because of the dialer or chopper, I am helping the phaco tip to bring it inside. Always manipulate the nucleus in the center because when the tip is in the center, definitely it will not going to damage the iris tissue. Use bimanual IA. As I said, why bimanual IA? Because if you are using both the hands, definitely that will help to go behind the iris, behind the pupillary margin, and you can catch the pupil. You can hold the capsule, and you can take all type of cortical matter, and bring it in the center and aspirate it. So I always use bimanual IA while using small pupil cataract surgeries. Management of small pupil with viscoelastic agents which will stretch the iris, lead to deepening of the AC and that leads to pupil dilatation. So here, as I say, whenever you are having small pupil, just do with iris, you can iris repositor, you can break the posterior synechia and with the help of Y hook, both sides perpendicular to each other, you can stretch the pupil. You can see in this video, first I did with iris repositor, we break the synechia, then we do with Y hooks, we stretch it perpendicular to each other and that will help you to make a pupil stretch and definitely will going to help you for the further procedure. Sometimes after doing this also, if you think that there will be the post-operative or intraoperative, it's going to meiosis. So give a small cut at the pupillary margin, and that will help you in doing the procedures. Here is one thing which is really great, but for the beginning, it's difficult for me also, because when you are using iris hook, you should know the tissue property or what is the main thing for the cataract, like it is a uveitis case or something. Because when you are using the iris hook, definitely you need to have 4 to 5 paracentesis incision. When you are using paracentesis incision, make it sure that when you are putting the paracentesis incision, you should not damage towards the iris tissue. Otherwise, that leads to bleeding, and that may again, during the procedure, sometimes it may get shallow anterior chamber, and if shallow anterior chamber is there, that will definitely giving you some trouble while doing surgeries. One more thing is that even though you are putting 4 hooks, you may need one more hook, just because if one more hook is there, that you have to be at the, when you are going to put the phaco probe, from the same point, iris tissue will come inside. So the 5th iris hook should be behind the main port. These are some pupil expansion devices. I'm using BHEX pupil expander. The procedure will be like the same, do synecholysis, breaking of the posterior synechia. Here, there are 2 things which are more important. You will get good hexagonal shape of pupil. How to insert it? There are 2 types. Either you go with the forceps, here as it is, or you go with the Sinskey hook. Both with the Sinskey hook or with the forceps, only thing is that make it sure where is the holes, because sometimes it's very difficult. We can insert it properly, but while doing, while we are going to do behind the iris, times it's difficult to go inside, and that again may lead to iris tissue. But it's very easy when you are going to have that hexagonal shape. The CCC will be proper, and it will give you a good surgical skill. Gupta pupil expander, this is also a good one, but need injector and cartridge. Only thing is that it is more helpful when you are going to have a square shape, and that will definitely help you to have a good surgical skill. Management of intraoperative meiosis, this is more important, because after doing everything, suddenly you can see, because of iris tissue or some handling with the tissue, with the, either with the dialer, chopper, you may get intraoperative meiosis. That nowadays a commercially available injection, tropicamide, phenylephrine, and lignocaine is there. You can put it inside, and again you can have a good look, and you can insert the lens. Advantage of hooks over the pupil expander. Technically much more easier to insert and remove. Pupil expander is difficult to insert after capsular axis. The iris hooks are much more reliable in such cases. Advantage of pupil expander over iris hook is no need for extra paracentesis, easy fixation points are there, smooth edges, less trauma to iris tissue, and flexibility. Thank you very much.
Thank you. Sir, yes, go ahead.
Yes, sir, go ahead.
Sir. Yes, sir. Yes, sir. Now it's not available, but before.
Nobody explained about the intracameral use of adrenaline, and I think we are forgetting the subconjunctival use of gentamicin and dexamethasone at the end of every cataract surgery. Still, I think dexamethasone has got good role
Right.
as far as inflammation is concerned, and adrenaline, intraoperative meiosis is prevented, bleeding is prevented. I'm using adrenaline in each and every case in AC maintainer through that line. Number 3, as a rheumatoid, this thing, cycloplegic and all other things, they are not useful. After operation, subconjunctival or subtenon use of depomedrol, that gives good anti-inflammatory effect for 21 days or more than that. So this is my observation. If anybody knows about depometrol, it is welcome. Thank you, sir.
Thank you, sir, for your suggestions and tips. Thank you, Sean. You have very well explained about how to manage small pupil in cataract surgery. There are different options. Whatever option you feel better in your hand, I think we should opt for that. So, excellent presentation as usual. Sean, thank you so much. Anybody has any comment, please? Anybody has any question? Yeah, so we'll go to the next presentation, Do and Don'ts in Premium IOLs by Dr. Subodh Purohit. He is from Yavatmal, Maharashtra.
Good morning, everybody. I'm going to speak on do's and don'ts in premium IOLs. After the birth of your child, if any surgery is more satisfying, that is the cataract surgery, I guess, and everybody will agree with this, provided you give a good vision to the patient. Now, basic aim of a premium IOL is to convert the cataract surgery into a refractive surgery. Now, what are the pearls for cataract surgery to be a refractive surgery? Pre-op pearls we can divide into pre-op pearls, intra-op pearls, and post-op pearls. Now, pre-op pearls for a premium IOLs, choosing a right patient is half battle won. Now, points to be considered for pre-op counseling, that is for the premium IOLs: acknowledge the patient need for near and the intermediate vision. Understand, is there any high level of concern, fear of a night vision related issues? Make sure that the patient understands that the neural adaptation is a process. And also make sure the patient has realistic expectations. If a patient is asking too many questions, if a patient is becoming more of an advocate, avoid such patients. There should be difference between, this is the most important thing I would like to say, seniors will agree with this, there should be a difference between selling the lens and educating the patient about the options available about the lens. Now, going for a preoperative assessment, ocular surface and tear film evaluation, rule out any ocular comorbidities, avoid any anisotropic or high myope or amblyopic patients. Preoperative refractive surgery, if at all patient has undergone, try to educate the patient, tell him that there is increased propensity of glare, halos, or IL power calculation, so avoid such patients. Now, though you are an anti-segment surgeon and the patient has got no retinal problems, but just make sure you go for a OCT pre-op assessment, and if at all, if you are in doubt, don't shy away to take the opinion of your retinal colleague. Now, too much of information will confuse the patient. Sorry, there is no interest in politics, though there are dates to be available, to be declared today, I guess. Don't confuse the patients like EDOP, multifocal, hydrophobic. Just imagine if you got a MD medicine colleague and if you say all these things, even he may get confused. So for a layman, it is very difficult to understand EDOF, premium, toric, bifocal, and everything. So avoid such confusion. Then after convincing the patient, go for the measurement of premium IOLs, because outcome depends on multiple factors. Precise preoperative measurements play an important role. And also, role of an advanced diagnostic technologies is more important for the perfection. Accurate biometry requisite, that is, you have to go for a keratometry, because we need magnitude of astigmatism and also the axis of astigmatism. Then axial length, AC depth, lens thickness, effective lens position. Because nowadays the newer formulas are based on the effective lens position and all these parameters. Optical biometry is must nowadays, like IOL Master 500, 700, Lens Star, because these give the keratometry markers of 1.65 mm and all the newer things to it. Because accuracy of IOL power is more important, because just guess you're going to stitch a suit suit for wearing into your wedding programs, and if you're buying like 10,000 per meter suit, but if it is not fitting you, it will make no sense. Now, applanation scan has got error of 0.24 mm, immersion scan like 0.12, and the most optical biometry is the most accurate, I'll guess. Now, appropriate formulas based on the axial length is very important, but for large, we can go for Barrett Universal 2 for most of the range of axial length. Then another thing I usually follow in my practice is triangle of agreement. That is, I usually take the 2 or 3 readings, which usually for, you can taper it to your common lenses you are using, like for Alcon, for IOC and others. If Haig's formula is perfect for you, or SRKT or Barrett Universal 2 is perfect. So take 3 and take best out of these 3. Then astigmatism and premium eyes, like preoperative corneal astigmatism, it is less than 1 diopter, go for multifocal or EDOF lenses. If it is more than 1 to 2.5, go for multifocal toric or the toric monofocal. If it is more than 2.5, monofocal toric I usually prefer, but we can go for toric multifocals also. Now, astigmatism update, initially we used to only consider anterior corneal astigmatism, but nowadays we have to add to posterior corneal astigmatism, SIA, and which is the total astigmatism. Now, understanding the posterior corneal astigmatism, because nowadays from last 5 to 7 years, we are talking too much about posterior corneal astigmatism. This means if the corneal astigmatism is calculated from measurements taken from anterior cornea only, we may land up in overcorrection in with the rule astigmatism or undercorrection in 0.30 by in the ATR, that is against the rule astigmatism. Now, optical system alignment is also important because the IOL tends to center on the limbal center and not on the visual axis. If you got a large angle cup alpha, that is 0.5 mm, avoid multifocal or the toric lenses. EDOF lenses is debatable. We can go for EDOF lenses. Now, if you can afford eye trace, if it is available, if there is too much of aberrations, avoid such patients. Needless to say, intraoperative pulse like incision should be perfect. Rexis should be 5.5, 360 degree, overlapping the IOL optic. Nucleotomy, if it is hard cataract or even if it is grade 3 and you're going for a premium lenses, don't shy away or don't do any conjugacy in using viscoat or high molecular viscoat. IOL stability is more important. Go at polishing and centration, especially in the toric lenses. Now, you always don't need flax. You can go with a manual CCC and this already. This is another important point I would like to say. These are the IOL centration. This is a P1 image, Purkinje image 1, which is with the base down and the apex at the top. The second image, that is P2, which is on the anterior, posterior surface of the cornea, which is a little bit blur. And P3, that is the Purkinje image 3, which is on the anterior surface of the lens. And P4 is the inverted triangular mark on the posterior surface of the lens. And what you have to do in alignment is you have to match Purkinje image 1 and Purkinje image 4 for the accurate alignment of the lens. Even after doing so many things, you may land up with unhappy patients. You may face unhappy patients. I say there are 6 C's, like cornea and ocular surface disease, cylinder, residual refractive error, capsular opacities, and the last but not the least is crazy patients. Now, negative dysphotopsia, like temporal peripheral pencil beams, when they hit the lens edge, and it may cause the shadow on the retina and may give rise to negative dysphotopsia. So I'll just get a couple of minutes, please. Positive dysphotopsia, glare, halos. We all know that these are the problems with the rings associated multifocal lenses. Now, neural adaptation is just like your spouse adaptation. I would have said only about the wife adaptation, but since females are sitting over here, I'll say it is like your spouse adaptation. It takes around 3 months to 1 year to get adjusted. So, खुद ही तो कहते थे मुझे खुद को बदल लो, खुद ही तो कहते थे मुझे खुद को बदल लो, अब बदला हूँ तो कह रही है अब वो ना रहे तुम. It is just a neural adaptation, but you have to get adjusted to it. Now, rotational stability, like rotation of 3.3% of lens cylinder will be lost for every 1 degree of IOL rotation, And if at all you find any disparity in the toric lens, you can go for astigmatismfix.com and realign it. To summarize, start with the hypermetro female patient, know patient's occupation very well, precise IOL power calculation. Multifocal and toric lenses are very sensitive to residual refractive error. The newer generation formula should be used, and important thing is promise less and deliver more. And after doing all this gymnastic or circus, even if you land up in some surprises of a cylindrical residual axis or, for example, spherical even, I'll say not all the postoperative patient with glasses would be unhappy and complaining, because we know one person or we know one patient who is happy with the glasses, and you all know this. Thank you. Pseudophakic patient we all know. Thank you.
Well, thank you, Subodh. It was wonderfully covered. And I think if I have to sum up the premium IOL thing, before you actually commit to a patient for premium IOLs, certain diagnostics should be a part of your armamentarium, like which you've emphasized about the OCT, the dry eye management, the good optical biometry, the specular and other stuff. We still have about 3 minutes. If anybody has any query, they can put up the question.
Most important point I like is that you should counsel the patient beforehand, and don't deliver more and promise less. These two things are very important for premium IOLs, I suppose. Thank you very much. All the speakers who have presented excellent talks today. We learned a lot, and there are so many pearls of wisdom we have got, and it will definitely help in our practice. Over to Doctor.
Thank you very much to all of you, and I just request all the presenters to be here for the group photograph, please.